For Raja, your great contribution to this opportunity and this wonderful webinar. So in this letter of the symposium about the spinal cord stimulation, and the spinal cord stimulation is very effective for neuropathic pain as well as the ischemic pain, but it has been also been used to improve motor recovery from a spinal cord injury. So I believe that this treatment will become increasingly important treatment in the near future. So the lecture, today's lecture will be given by the Professor Matis from Germany. The title is Spinal cord stimulation, a melody for the brain, which is a very, very interesting title. So I'm really looking forward to hear your great presentation. So Professor Matis, thank you for your time to give us a great lecture. So could you start your lecture, please?
Thank you very much for your kind introduction. Thank you very much for the invitation. The first lecture today was excellent. Congratulations. And let me share my screen. I think you can see it. So let's start. My conflicts of interest, I must reveal everything here, but I don't think it's really relevant. The agenda, over the next minutes, we're going to speak a little bit about neuromodulation, because I'm sure there are colleagues among us who never heard about neuromodulation, about the current role of spinal cord stimulation in interventional pain management, about the new waveforms, and about the future of spinal cord stimulation. Let's start with the definition. Neuromodulation. What is neuromodulation? Is it all about cables or maybe not? If you visit the website of the International Neuromodulation Society, you will find there the following definition. Neuromodulation can be defined as the alteration of nerve activity through targeted delivery of a stimulus, such as electrical stimulation or chemical agents, to specific neurological sites in the body. There are many diseases that could be treated with neuromodulation, among others, Parkinson's disease, essential tremor, medically refractory epilepsy, pain, and this is the main topic of today's lecture, spasticity, urologic disorders, fecal incontinence, pelvic floor disorders, gastric disorders, and many, many more. But in my eyes, this is also neuromodulation. This is Bini, this is my dog. She is now 8 months old. We adopted her from Croatia. And this is also a type of neuromodulation. And Bini, just like our chronic pain patients, needs much time and much dedication. What about the current role of spinal cord stimulation therapy? Which patients could be good candidates for such a therapy? We have patients with trigeminal neuropathy. Please be careful, not trigeminal neuralgia, trigeminal neuropathy. Patients with back pain, neck pain, arm pain, leg pain, phantom and stump pain, polyneuropathies, patients with diabetes mellitus, for example, or after chemotherapy, patients with plexus lesions, with angina pectoris, with peripheral vascular disease, post-herpetic neuralgia, and complex regional pain syndrome with or without capsalgia. Well, here, the train is the patient. The man is the physician, who is trying to remove all obstacles in the chronic pain journey of the patient. It's not something easy to do, but we have to do it and we have to do our best. So I think you got my point. And let me continue with a provocative question. What is it like to be a microchiropteron? Or otherwise, what is it like to be a bat? This was the title of an article published in 1974 in the Philosophical Review. It was about the consciousness, and the author, Thomas Nagel, wrote, these experiences, for example, pain, hunger, also have in each case a specific subjective character, which it is beyond our ability to conceive. So pain is also very subjective. And it's the same thing with people who cannot hear us or see us. We don't really know what it's like to be like these people. And it's becoming even worse. This is the pain detect questionnaire, the German version of it. The patient should actually tell us how much pain he has, and he wrote these numbers down. Later on, it took 5 physicians to see that's actually the telephone number of the patient and not the pain intensity. The interventional pain therapy. There are many therapies, they are acting at different levels. So at the level of the first neuron, we have the dorsal root stimulation, we have the pulse radiofrequency stimulation, we have peripheral nerve stimulation, the implantation of leads subcutaneously, or peripheral nerve stimulation, implantation of leads directly where the nerves are. At the level of the second neuron, we have the spinal cord stimulation and the intrathecal therapy with or without opioids or combination of these drugs. At the level of the third neuron, we have the motor cortex stimulation and deep brain stimulation. I think you are all familiar with the World Health Organization ladder. We should start our therapy with non-opioids, then use weak opioids, then stroke opioids, and in the end, the intrathecal therapy. But we have seen that if we start with all these neuromodulation options, such as subcutaneous leads or pulse radiofrequency or spinal cord stimulation, before even trying the opioids, then the clinical results are much, much better. And this is not what I'm saying. There have been publications on this topic. One of them is the article of Dr. McGuire and Dr. Slavin 2020. And the authors are saying that actually now we have a trend or a paradigm shift toward an earlier surgical intervention. And this could have profound implications, not only for our patients, but also for the public health. Everything started with this article, published in Science 1965, Pain Mechanisms, a New Theory. It is the well-known gate control theory, which states that the activation of large fiber fibers inhibits the transmission of pain to the brain. Once again, 1965. The first clinical application took place in 1967. 2 years later, it was a patient with bronchogenic carcinoma. His daughter was an anesthesiology nurse, and she convinced her father to accept this operation. It was experimental back then. The patient accepted. He was satisfied. He had a pain relief, but 6 days after the operation, he died because of endocarditis. So the very first operation took 1967 place. This is not a new therapy. What are we stimulating? We are stimulating the dorsal columns. We are stimulating the dorsal horns. Actually, we have to implant 1 or 2 leads epidurally in the spinal canal, where the spinal cord is, make a test, a trial, and if the patient is satisfied, connect these leads to the permanent battery, to the permanent IPG, to the permanent implantable pulse generator. How it works, nobody knows with certainty, although this is an FDA-approved therapy and a really old therapy. There are segmental spinal effects, but there is also a supraspinal modulating mechanism via descending pathways. There are many basic research articles published. You can find all of them in PubMed. There are many mechanisms, there are many hypotheses, but 100% we cannot be sure about this action. And this is why we are needing different types of stimulation. The history of this therapy in Germany. This is a photo coming from 1974. This was the first spinal cord stimulation meeting in Freiburg in the southern part of Germany. And all the devices you can see here are radiofrequency receivers. They were devices. The colleagues back then implanted them under the skin subcutaneously. And each time the patient wanted to stimulate, should place this round antenna over the radiofrequency receiver. These were the very first steps. And we started, or the colleagues started back then with leads which had only 1 contact. Today, we have much more variety. We have leads with 16, with 8, with 32 contacts. Back then, we started with 1 contact, with 2 contacts, with 4 contacts. We have the percutaneous placed leads, we have surgical leads. So the options are really big. It is true, and this is true for all therapies, that if we want to offer patients a good solution to their problem, we have to follow some rules. There are some indications, there are some contraindications, and some gray zones. And by the way, this is the University Hospital of Cologne. This is my home. In Germany, we have these S3 guidelines. There are inclusion criteria and exclusion criteria. The patient could be a candidate for this therapy if the chronic pain cannot be sufficiently treated with drugs or psychological therapy. Exclusion criteria, and this is more important, patients with severe coagulopathies, with mental disturbances, with addiction problems, with secondary gains, inability to use the spinal cord stimulation system, an advanced malignant tumor, and of course, infections in the area of implantation. According to the German Neuromodulation Society, the best two indications for this therapy is CRPS type 1, complex regional pain syndrome, and failed back surgery syndrome, or the new name now, persistent spinal pain syndrome. Other indications such as angina pectoris or peripheral vascular disease, the indication is open, or the recommendation is open, although the patients are really good candidates for this therapy. The majority of patients that are coming to us are persistent spinal pain syndrome or failed back surgery syndrome patients that have been operated on in the lumbar spine, and after the operation they keep having pain. And we know there are many articles on this topic that the failure rate of lumbar spine surgery lies somewhere between 10 and 46%. And that means that many patients are not satisfied. But we don't have only patients with back pain and leg pain. We have also patients with other diseases and other good indications, such as the intractable angina pectoris. Here we can place a lead with the tip at C7 or T1 on the left side. And if a heart attack is coming, the lead cannot hide this attack, so the patient is going to notice that the heart attack is there. This is a common question that people usually ask. Patients with peripheral vascular disease, the best patients are patients with stage 2B and 3, but some patients in stage 4 could be candidates. Here we should place a lead with the tip at T10 in the midline for both legs. On the right side of the slide, you can see the temperature of the foot before starting the therapy, control, and 30 minutes after. You see the color is completely different. After 30 minutes, it's more red. Red means more blood is coming in this area, so we can improve the quantity of blood that is coming, and we can improve the chronic pain. If you're interested in this topic, you could read our review article published in British Journal of Neurosurgery on spinal cord stimulation and PVD. Please keep in mind that spinal cord stimulation could be used at the same time or combined with peripheral nerve field stimulation. This is an example of a patient who had an accident, a bicycle accident. You can see where the problem was on the left picture. You can see the scar. Initially, the colleagues had implanted 2 leads parallel to the scar. The patient was satisfied. 6-7 years later, came back with an increase of pain, and then the colleagues implanted a second lead, a spinal cord stimulation lead. And now the patient has both therapies, spinal cord stimulation and peripheral nerve field stimulation therapy. The classical stimulation is the tonic stimulation, a paresthesia stimulation, meaning that the patients are feeling a tingling. They are having a tingling sensation. This animation comes from a specific company, but as you know, the companies...
Chronic pain can arise from numerous conditions and have many negative impacts on a person's life. Hyperactivity of the wide dynamic range neurons, or WDRs, which project pain signals to the brain, is believed to contribute to chronic pain. The goal of spinal cord stimulation is to suppress this neural hyperactivity and therefore reduce pain signaling to the brain. Treatment for chronic back and leg pain includes the use of traditional spinal cord stimulation, SCS, in which dorsal column fibers are targeted to reduce pain. Traditional SCS delivers strong low-frequency pulses to activate these dorsal column fibers, generating paresthesia, a tingling sensation that must cover the patient's painful area. Obtaining and maintaining paresthesia coverage for back pain can be difficult, leading to poor long-term outcomes. HF10 therapy has been uniquely developed as a more efficacious and paresthesia-free therapy. Rather than stimulating the dorsal columns, it is believed to work by more directly targeting the dorsal horn, using consistent lead placement proximal to the painful spinal segments and a high frequency of 10 kHz. The result is greater neural inhibition and thus greater efficacy.
So we have the tonic stimulation, we have the high frequency stimulation, we also have the burst stimulation. Here are packets of high frequency pulses delivered to the spinal cord. This is also subperception, no tingling sensation. And we have now new waveforms. We have the possibility of frequency pairing, meaning that we can apply a tonic stimulation and then high frequency and then again high, then tonic stimulation and so on, or burst and high frequency and once again burst, not at the same time, but sequentially. We have also the real combination therapy. This means if we have only one pain area, we can apply two waveforms, two types of stimulation, a tonic stimulation, for example, and a subperception waveform. If we have multiple pain areas, we can apply, for example, for back pain, a subperception waveform, and we can apply for leg pain, a tonic stimulation. We have also the possibility to try multiple therapies, multiple waveforms sequentially. The goal here is to address the issue of habituation, or in other words, the issue of loss of efficacy. We all know that in some patients, after some months or years, the pain is even stronger, and we'll have to adapt our stimulation to this pain. This is why it's important to have many waveforms in order to address the issue of habituation. And this was the first neurostimulator that was implanted in Europe with the ability to offer this combination therapy. It was implanted in my hospital. 2 years later, the MRI compatible version of the same neurostimulator, also in the University Hospital of Cologne, because it's important to offer to our patients a system that can provide different types of stimulation, but at the same time, the system should be also MRI compatible. This is what our reps are seeing when they're doing the programming. We're seeing the lead. We can adjust many parameters, the amplitude, the pulse width, the frequency. We can save different programs and do different combinations. And the concept here is that if we use different types of stimulation, we can at the same time stimulate the dorsal horns, we can stimulate the dorsal columns, we can stimulate different neural targets. And this could help in the long run for this habituation issue. This graphic comes from a publication from my department in neuromodulation in patients who came back to us after the implantation of the system, after some years, and they told us that the pain is back. Instead of removing the system, we externalized the leads and we tried in all these patients the combination therapy. And we have seen that almost 90% of patients reported better clinical outcomes with a combination of multiple waveforms. Once again, it doesn't really matter what type of waveforms. What is really important is to have an option. A new technology, the closed loop stimulation. This article was published or was accepted in 2017 in Neuromodulation. The concept here is that the lead does stimulate like all leads, but at the same time can measure the reaction of the spinal cord. How is that possible? The lead can measure and capture the ECAPs, the evoked compound action potentials, compare the amplitude with a set point, calculate a new stimulation current, and then generate new stimuli. Why is this important? The classical open loop systems, the lower part of the picture, we can see that the stimulation, the black line, is not always within the therapeutic window. It is important what the patient is doing. If the patient is standing or sitting or is supine, then the stimulation is different, meaning that the patient can get a hyperstimulation or a hypostimulation. With the closed loop system, you see that the stimulation, the black line, stays almost always within this therapeutic window. And what the patient is actually doing, if he's studying or sitting or doing something else, it's not important. An animation coming from the specific company showing the concept. We stimulate. Because of the stimulation, ECAPs are generated. The lead can capture these ECAPs and correspondingly adjust the stimulation. If you open your physiology book, you will see this picture here on the upper right corner with an ECAP with 2 positive waves, 1 negative wave. In the operating room, we see this picture here, the orange picture. This is a new, very promising therapy. There are results, clinical results. There is a study, Avalon study coming from Australia with 12 months results. We have an Evoke study coming from the United States with 12-month results, all of them published in very good journals. And now we have also for both studies 24-month results. To make our life easier, I made up this table to show you the results. So at least 50% pain relief, back and leg pain, after 2 years remains pretty good. What about the profound responders? Patients who have more than 80% pain relief. It is also really good. For me, it's more important that the stimulation stays within this therapeutic window, and maybe this is the reason why the results are so good even after 2 years. And even more important, that we have 67 to 83% of patients, depending on the study, who eliminated or reduced the opioid intake. All of these studies, you can see the sources are published in really good journals. And this is how it looks in real life. The leads have 12 codacs, meaning we can cover almost 3 vertebral bodies. During the first 4 weeks, we use the open loop, the classical stimulation, and when the impedances are stable, after 4 weeks, the patients are coming back to our outpatient department and we change to the closed loop stimulation. Another waveform or another algorithm is this differential target multiplexed, meaning that with this algorithm, we are using multiple signals for modulating not only neurons, but also glial cells. Is this important? Yes, it is important because glial cells are involved in various processes. They are involved in neuroinflammation, they are involved in amplification, modulation, and distortion of afferent sensory signals, and they outnumber neurons in a spinal cord with a ratio of 12 to 1. There are publications that have been conducted, research conducted on animals showing that results with DTM are better as compared to the results with low and high frequency. There are results in humans showing that the back pain starting from 7.4 is down to 2.4 and leg pain from 6 to 9.4. This is the neurostimulator that can provide this algorithm. One should keep in mind that the onset of action comes not immediately. It could be some hours, it could be up to 2 days. And the placement of the lead is really important. With 2 leads, we should cover the T8 to T10 space. And we have 4 programs that are running parallel. We have a basic program with 50 Hertz, and we have 3 prime programs with 300 Hertz. You got the point. We have many waveforms. Is that important? And if yes, why? This is Alma Deutscher. Some people think she's the new Mozart. She loves improvisations. Have a look at the video.
Notes. If you could pick some 4 notes from this hat, and then I will improvise a piece based on the notes.
All right, hand me that. Close my eyes.
Close your eyes. Si bemol. Mi. Si bemol. La.
as Alban says, the most important thing in music is the melody. It does not have to be very complex, but actually people should like to listen and enjoy it. So, for me, spinal cord stimulation is music, is mathematics. The definition of music is the science or art of ordering tones or sounds in succession, in combination, and in temporal relationships to produce a composition having unity and continuity. And this is really relevant to all these waveforms that we are using now in spinal cord stimulation therapy. I'm coming from Greece. I must say something about ancient Greece. So in ancient Greece, music was called originally any artistic or intellectual pursuit and was associated with mathematics. So a little bit of philosophy is also good. And we do know that if we use different waveforms, we can stimulate different areas in the brain. This was shown and presented at NANS, North American Neuromodulation Society meeting 2015 with tonic stimulation and 1 kilohertz stimulation. So different waveforms are acting in a different way. It's a different type of music for our brain. The second reason why the majority of these waveforms is important, or the more options we have with waveforms is really important, is that we could not do the screening trials. There have been some publications, most of them are coming from the United Kingdom, and COVID has played a tremendous role. This is a very interesting publication from Duarte and Thompson, and they showed that if the success rate of a trial when we are using rechargeable systems with batteries, is 85% or more, or 55% if we are using non-rechargeable systems, then it is effective not to do a screening trial. And the colleagues are saying that if we do the trial, we could have more infections, we could have more punctures, productivity losses. And the main question is, are trials really predictive of long-term outcomes? To be honest, I would always do a trial. It doesn't matter if I have 10 different waveforms, I would also do a trial. But this is another trait in specific countries, we should respect it. Another very interesting article published in Pain from Professor Eldab and his team was this one, showing that the sensitivity of a screening trial is 100%, but the specificity is only 8%. And the authors conclude that although a screening trial may have some diagnostic utility, it provides no patient outcome benefits. What about patients with virgin back, patients that do have back pain or back and leg pain, but they have never been operated before? This is a study conducted with 10 kilohertz as a frequency, and we saw that after 12 months, the back and leg pain is much better. More importantly, the Oswestry Disability Index, or the severe disability, is much better, and the morphine milligram equivalents are even more better. The future, where are we going to? While spinal cord stimulation could play a role, at this time point, it's a good option for patients with comorbidities, for cosmetic reasons, if the patients would like to have only this system, and if the patients don't really like bulky neurostimulators. With the wireless system, we implant only a lead epidurally. We don't implant a battery, but each time the patient wants to stimulate, should wear this blue antenna over the skin, over the lead, and this transmitter. Without the antenna, the therapy is not working. This is how the lead looks like. This is once again how the antenna and the transmitter looks like. Of course, the main advantage is that the volume of the system is really low, less than 1 cc, when the smallest IPG in the market has a volume of 14 cc's, but there are some limitations. The future is also more data. If you have some time, you can read my editorial in Interventional Pain Medicine Neuromodulation journal. We all have smart watches, Apple watches. We have many apps in our phones. All of these things can collect various data And artificial intelligence or machine learning can use all of this data to optimize or to improve the spinal cord stimulation therapy. All companies are working in this field. I'm sure that in the future we're going to have even more waveforms, and this is a good thing. The newest thing that we have is the fast acting subperception therapy, a waveform subperception, 90 Hz frequency without any tingling sensation. And the good thing here is that the pain relief comes within seconds or minutes when it works. And let me take you one step further. It seems that the newer waveforms can partially help patients with mixed pain, patients with a combination of neuropathic and nociceptive pain. This poster was presented at the European Federation of Pain Congress in Dublin this year, showing that people with a mixed pain syndrome could benefit from this waveform. It's about the fast wave.
Professor Warren Grill of Duke University recently explored the impact of surround inhibition on SCS. Here's how it works. In the gate control theory, small sensory fibers send pain signals to the wide dynamic range or WDR neurons, which are then transmitted to the brain. Conventional SCS activates larger sensory A-beta fibers from the center area of pain. These fibers activate inhibitory neurons, which limit WDR firing and immediately reduce pain, despite also causing some WDR excitation. Conventional SCS also activates some sensory A-beta fibers from the region surrounding the painful center. These fibers only engage inhibition without exciting the center WDR neuron, providing additional immediate pain relief. Using the proprietary Illumina 3D algorithm, we're able to more precisely target the optimal location, covering more of the surround fibers. Combining Illumina 3D targeting with the proper neural dose and a unique active recharge waveform, FAST is designed to preferentially engage these surround fibers while minimizing center excitation. As a result, patients can experience profound paresthesia-free pain relief before they leave your clinic.
Just one more option. An interesting publication from many European colleagues, it's all about referral and selection of patients. Based on this publication, a company has made up this website, the eHealth tool. It's free. You can register there. And there are some questionnaires. We should give some data of your patient about his pain, about his history, or psychological data, and the system will make a recommendation if the patient is a good or a bad candidate for spinal cord stimulation. Actually, this website could be of value mainly for general practitioners, but it is a start. The point here is to raise awareness about the therapy and motivate colleagues, general practitioners, neurologists, anesthesiologists to refer patients to colleagues that are performing these spinal cord stimulation therapies. The future could also be this merged reality. Merged reality means blending two real-time video streams into a collaborative, interactive environment. An example, this is me. I had an accident 1 year ago. Imagine I would like to do a reprogramming. I have difficulties. My rep, who is an expert in this field, is in Greece, somewhere in the beach. He can see what I'm seeing, and he can show me in my mobile phone what I should do, how I should program it. It's a big help in some cases, not for all patients. What's new, you will see many companies speaking about this, is this remote programming. Remote programming could be a solution in some countries, in some cases, but according to my opinion, it's not be the mainstay. Nonetheless, it's a good option to have, and we use it also in my department. Here you can see me, but also you can see two reps from a specific company. The one is in the hospital, is with the patient. The second one is in Greece, having a good time, and we can talk all of us together at the same time with the patient, and we can see all together what would be the best programming option for this patient. And let me tell you, the patient is very satisfied. As you already mentioned, spinal cord stimulation could be used for patients with paralysis, complete or incomplete paralysis. This is a really, really good article published in Nature Medicine, and one of the authors would be in the International Neuromodulation Society International Congress in Maine, Barcelona, and present his work there. But please let me tell you, we are just in the very, very first steps of this therapy. We should not have huge expectations. An integral part of the whole concept here is the rehabilitation. It plays a huge role, and the lead, of course, helps. So once again, we are in the very, very beginning. We must wait a few years to get much better results, but it's really very promising. So when I was a kid, we didn't have internet, but we did have TV. One of my favorite things was Motor Times with Charlie Chaplin, an old movie. Charlie Chaplin was working in a factory, and every day he should do the same repetitive movement. And when somebody doing the same thing, there are contraindications. The patients are not products. There are patients, they have different needs. This is why it is imperative to have many options, many wavelengths, if you like, in this spinal cord stimulation therapy in order to offer the best possible option to each person. We are speaking about an individualized therapy without such complications. Above all, spinal cord stimulation or treatment of chronic pain patients is a teamwork. It's not a one-man show. It's not about a surgeon who is implanting one or two leads. It's about a whole team of neurologists, neurosurgeons, orthopedic surgeons, psychologists, anesthesiologists, and so on. Of course, compassion is an integral part of the whole therapy, something that's absolutely a must. A collaboration, a national collaboration, international collaboration is always a must. I'm very happy to be here today with you. We can all speak together about this therapy and raise awareness about this therapy. I would like to thank my sales reps from different companies that help me to do the optimal programming for each patient. And as you can see in these pictures, we are really having fun together. It's not only a job for us. So I hope that the chronic pain patients that could be good candidates for this therapy would find the way to this therapy and in the end be exactly so happy as my dog when I'm getting back home. If you would like, you could follow the official social media accounts of the neuromodulation technology at the neural interface. This is the official journal of the International Neuromodulation Society. If you have not already registered, I think it would be a good idea to register for this Congress here in Barcelona in the end of May. It's going to be an amazing Congress. I hope to see you, many of you there in this Congress. And with that, I finish my presentation. I thank you once again for the invitation. Should you have any questions, please don't hesitate to ask me, or if you want, just send me an email. My email address is on this slide. Thank you very much.
Okay, thank you. Thank you for Dr. Matis, Professor Matis. It's a great lecture, and I totally agree with you. Music and mathematics and spinal cord stimulation. I now understand why is it difficult to understand the principles and the effects of the spinal cord stimulation, because I am not good at both music and mathematics. But today's lecture was very educational and very easy to understand. So, and thank you very much for your great lecture that gave us a very broad understanding of the basic principles of the spinal cord stimulation and its future perspectives. So, is there any questions on the audience?
Yes, yeah. Thanks, Professor Matis, for very nice and very nice videos and on how neuromodulation works. My question is, in your experience, is there a moment that we can actually wean off the device and the neuromodulation effect will be permanent? Do you experience such occasion? And my second question, Prof, how do you balance between medication and spinal cord stimulation? How do you the effect of both? Thank you, Prof.
Thank you for the questions. Let me start with the second question. I'm afraid I couldn't hear your first one. You will have to repeat it. But for the second,
disconnected. Is it Prof. Matis?
I cannot hear
Professor?
your voice. There are interruptions. I cannot hear you well. I heard only the second question.
Yes. Only for a second question, please.
For the second question, you can write if you can write the first question.
The first question, Professor.
It will be easier.
Yeah, I mean.
So for all patients should try all the traditional ways, should take medications, should try physiotherapy, should try psychological support, cognitive behavioral therapy, and all of these things. But if they see that this doesn't work out for them, they should not wait 20 years to find another solution. There are publications that show that if we offer this therapy within the first 5 years after the onset of pain, the clinical results are much, much better. After this time period, the results are also good, but not that good. This is why I think it's a reasonable time period of 5 years to decide if the conventional management is enough for a patient or not. And in order to be honest as well, the spinal cord stimulation is not the only therapy. It should not be seen as the only therapy. It's only a part of the therapy, meaning that after the implantation of spinal cord stimulation, most probably the patients are going to need some medications, but not so much as before the operation. They are going to need physiotherapy sessions. They're going to need psychological support. As I said, this is not a one-man show. It's not a one-man therapy. It's only a part of the therapy. And this is where we have difficulties when we're speaking with the patients because they have too high expectations. We are trying to reduce these expectations pre-operatively, not after the operation, but still the expectations are so high that the patients are not really hearing what we are saying. Most patients will need after the operation medications, hopefully no opioids. Some other medications could have adverse effects as well, but not the very high doses of them. So once again, this is really important. The patient should try everything else, medications, physiotherapy, psychological therapy, everything else. But if they see after 3, 4, 5 years that no substantial pain relief is there, then they should not wait any longer. The next step is a neuromodulation. Would you be so kind to ask once again the first question?
Yeah, my first question, have you ever experienced the neuromodulation effect became a permanent effect where you doesn't need a further neuromodulation? Does it cause a permanent effect? Thank you, Professor.
This is a really, really good question. I'm sorry I didn't hear it in the first place. There are such patients, but this is the minority. We are speaking about, let's say, 5% of the patients, not more. I have the privilege to work in this department where neuromodulation actually started here in Germany. So I have the privilege to see patients who have been operated 20 years ago. And there are patients that are coming back, they're asking us to explant the system. And when we are asking why are you not satisfied with the therapy, and we are waiting to hear loss of efficacy, habituation, they say, no, we're really satisfied, but we don't need anymore. We don't have any pain anymore. But if we look up the history of the patient, we see that in such patients, the colleagues back then offered this therapy very early. And I think this is the crucial point. I have never seen an explantation because a patient was satisfied by patients who had this therapy 10 years after the onset of pain. I did see some patients who tried spinal cord stimulation in the first 2-3 years after the onset of pain. Time is crucial. In stroke, we say that time is brain, but also in chronic pain management, time is also pain relief.
Thank you very much, Professor. Thank you.
Okay, I have several questions, Professor Matis. Okay, so the waveform of spinal cord stimulation is a little bit complex and difficult to understand. And in what order are the waveforms used? So do you start the tonic stimulation at first, always? Or for the conventional neuropathic pain?
Thank you. I will rephrase the question. I will say it a little bit different. The most important thing is to do a really good intraoperative trial. This is personally, I do not agree with my colleagues in the United Kingdom who are saying no trial, just implant the system if the indication is okay. I'm working in such a setting, it's a university hospital. I have the time, and this is a luxury, to do a very good intraoperative testing, meaning I can, in the majority of the cases, not in all patients, but in the majority of the cases, I can cover the painful area with this tingling cessation, with paresthesias. And this is, for me, a prerequisite for the success of this therapy, for the immediate success, but for the long-acting effect of the therapy. If I am sure that I have covered the painful area with the paresthesias, then I can be pretty confident that also in the future, using other waveforms, I could get exactly the same good results or even better. Nobody knows which waveform is the best for its patient. This is why it's good to have a system which provides all these types of stimulation, but also that we, as a surgeon or anesthesiologist who is doing the surgeries, that we implant the leads in such a way that in the future we can make the most of all these waveforms, because there are some prerequisites for its waveform. There is a specific way to implant the leads in the spinal cord. This is not only the art of the surgeon, it's also science. And the trick here is to implant the leads in such a way that you can have a good coverage of the pain area, but at the same time, all other waveforms, subperception waveforms, can also be applied. And don't forget there are patients that are needing a combination of these waveforms. Don't forget also that there are patients that are coming after some years, they say, my pain is back. One option could be to switch off the stimulation for 3 to 6 months. It's a reset. It's the same what we're doing with the computers. It's exactly the same. In some patients, after some months, the spinal cord is responding to the stimulation. Once again, it's holy. In the intrathecal therapy, we're speaking in the baclofen therapy about drug holiday, when we empty the pump and we don't use any baclofen for some weeks. This is also, if you like, an electricity or a stimulation holiday for some time, no stimulation, then it starts working. If these approaches are not working for the patient, then one should try with different waveforms. In the majority of cases, it works. Not in all patients, and this is the challenge. This is why all the companies, all physicians should keep working in this field till we find such waveforms that can cover the needs of all patients. So there is lots of work to do.
Okay, thank you. So, and I think the spinal cord stimulation is the most effective for ischemic pain, such as AS or other ischemic pain can be dramatically improved. However, in Japan, cardiologists do not understand the spinal cord stimulation, and it's very difficult to convince them of its usefulness. So this is why spinal cord stimulation for ischemic pain is not performed very often in Japan. So what is the situation in your country?
If it makes you feel a little bit better, it's the same story here in Germany. The cardiologists, if we're speaking about angina pectoris patients, or the vascular surgeons, if we're speaking about PVD, peripheral vascular disease, are not really cooperative. Although we showed them the studies, we showed them the clinical results, we sent them patients with a spinal cord stimulation system to see the effect of the therapy. It doesn't really working well, but it's a pity, because with this spinal cord stimulation, especially for patients with critical limb ischemia, you have a therapy for the vessels to improve the diameter of the vessels. You can offer pain relief, and just in case the patient has an amputation, you have already the lead in the spinal cord. You can treat stump pain and phantom pain. So you have with one lead 4 therapies. But we have exactly the same problem here.
Okay, thank you. Thank you very much. So so we do not have any question at this moment. So okay, so I would like to finish this session. So thank you for Professor Matis, a great lecture.
Thank you very much.
Thank you for joining us, everyone.
Thank you. Thank you, Professor Matis and Professor Horisawa for chairing this session. So before ending, on behalf of Education Committee of the ACNS and President Professor Yogo Kato, I would like to thank both speakers of today, Professor Walid Brijigji and Professor Georgios Matis, as well as our chair, Professor Akio Hodo, and also Professor Shiro Horisawa for the time and support for the ACNS webinar. I would like also express my sincere gratitude to Professor Zubin for broadcast. Raja mentioned we have more than 800 participants from all three different channels. So until we meet again on Saturday, is bye-bye from all of us. Thank you, Professor, for joining. Thank you. Bye-bye.